Hello, everyone, and welcome to the mini symposia session that we're having right now on linking administrative data sets to support firearm injury research. I'm Patrick Carter. I'm part of the FACTS leadership team here at the University of Michigan, and I'm really excited to hear from our panelists today. Access to quality data in the field of firearm injury prevention is really a key issue and a key scientific issue, and we're going to hear from three great panelists today on work that they have been doing to address how to better link data and to utilize that data to do high quality research. So I'll start by introducing our presenters. First up, we're going to have Dr. Ali Rowhani-Rahbar, who is an associate professor at the University of Washington School of Public Health and a FACTS faculty member, and he'll present on the linkage of criminal justice and injury data. Our second speaker will be Dr. Kathleen Carlson, who is an associate professor at the Oregon Health and Science University, and she will present on her project to integrate federal and state databases. Finally, our third speaker will be Dr. Libby Alpern, who is a professor of pediatrics at the Center for Healthcare Studies at Northwestern University, also a FACTS faculty member, and she will present on linkage of hospital data from the PCARN registry and the Children's Hospital Association of Pediatric Health Information Systems. Before we get started, I want to go over a few housekeeping issues for the session. After we've heard from the presenters, we'll have time for questions. If you're interested in submitting a question, and I do encourage you to do so, please use the Q&A feature, which is located at the bottom of your menu bar on the Zoom screen. We encourage you to send in questions throughout the presentation, and our behind-the-scenes staff will help organize them so that we have time to ask as many questions as possible before the end of the session. As a reminder, the session is being recorded and only the presenters and the moderator will be visible throughout the session. We've disabled the chat feature, so please do use that Q&A feature for all of your questions. We do have at the bottom of the screen also a live transcript available for accessibility issues. If you prefer to hide this function, it should be turned on automatically. Please click on the up arrow next to the transcript button and select the hide transcript. At this time, I would ask our staff, Lisa, to please share Ali's slides, and I'll turn it over to him for the first talk.
Great, thank you very much, Dr. Carter, and please let me know if you can't hear me well. So delighted to be here. I can see the number of participants is growing, and it's wonderful to be with all of you. I'm presenting the work here that really was done and was led by Dr. Vivian Lyons, who some of you may know. She is a FACTS postdoc. She received her PhD in epidemiology at the University of Washington, and she truly led this effort. I was fortunate to be serving as a chair of her dissertation committee. So I'm presenting today because she's about to welcome a baby to this world anytime now. The next slide, please. The funding for this work came from the city of Seattle, Arnold Ventures, and National Institutes of Health, a variety of different mechanisms. And as I mentioned, obviously FACTS also supported Dr. Lyons' work. Next, please. I'm going to be presenting on a wide variety of different data sets and databases that we used in the state of Washington. So I just want to thank all our partners and state level authorities and colleagues who really worked with us through this project to make it happen. The results that we present are essentially things that we found in this project and represent our views and not theirs. Next, please. So the goal of the presentation today is to really walk you through what happened, walk you through the story of the linkage of these databases that we did over the past 3 or 4 years, or Vivian did in the past 3 or 4 years, and just really hear also from you afterwards, maybe in Q&A session, about your thoughts about this type of work, and as you also listen to other presenters today. Next, please. I'll just share with you a little bit about this study that was the impetus essentially for all these linkages I'm going to be talking about. This was a study called HiFi, helping individuals with firearm injuries. This is the first randomized controlled trial, excuse me, of individuals who presented with firearm injuries or gunshot wound to Harborview Medical Center. It was an assessment of a behavioral intervention among these patients. So one arm received a behavioral intervention. It was a hospital-based and community-based intervention. And then there was a control arm or usual care. Next one. The main outcomes of interest for the study was the so-called recidivism outcomes that you see in this type of research. So arrest was the primary outcome. And then you had secondary outcomes. Next, please. Secondary outcomes such as injury, mental health, aggression, and substance use. And our goal here really was to focus mainly on arrest and injury because these were the two most salient ones. The other outcomes were captured by a self-report. So I will talk about arrest and injury today. Next, please. And next. I would say that, as many of you probably know, when you do these type of follow-up studies, whether it's a cohort study or a randomized trial, you always have to be very careful about the calculation of time at risk, the censoring, the competing, who is at risk, who is not at risk. So if you're thinking about assessing the risk of arrest when somebody is in the community, or the risk of sustaining an injury when somebody is in the community, what are you supposed to do when they are hospitalized? What are you supposed to do when they're actually in jail? What are you supposed to do when they move out of the state or they die? So those nuances methodologically are really, really important. And in order to do a good job, you have to be able to link many databases to really understand the longitudinal trajectory of these individuals and be able to actually partition that time accurately. Next, please. I think there are some animations on the slide, so we would just ask you to go next, please. Thank you. And then the geographic spread of this study here is shown. We included these counties that you see in Washington State because we had a support specialist or interventionist who had to travel across state and deliver the intervention. So it wasn't really possible to do a study across the entire state or in the region. Harborview Medical Center is a large trauma center. It receives patients, covers patients or catchment area across the whole WWAMI region across 5 or 6 different states. So people do come to Harborview from Idaho, Montana, Alaska, Wyoming, but our interventionist was limited in that she had to travel in certain counties. And that's why you see that certain counties only are included. Next, please. And next. And please keep going. So what we did in this study was to link 11 different data sets. Next, please. And 5 of them were linked probabilistically. The other 1 were linked deterministically. And next. And the next one, please. And just keep, yeah, if you could keep doing that, that would be great. Thank you. What happened here was that we needed to think about which organization to get the data from. What are the data sets that they need to be taken from each of these organizations and what the outcome are going to be. If you please just please continue. Yeah, this is a large slide and each of them have these animations that probably we should have removed before, so I apologize. And it's a very complicated scheme that I don't have time to describe to all of you in the next 4 minutes that's remaining from my talk. But I just want to give you a qualitative sense of appreciation of this type of work and what it entails, and you'll see in the talk for my colleagues as well. This type of work requires a lot of these linkages across different databases. And some of them may have, in terms of quality, may have better quality. Some of them may not have high quality. And some of it is guesswork and truly probabilistic work to really guess whether this is probably a true linkage or not. Next one. And next. And here are some of the numbers for you to see, for example, that essentially you could ask yourself, what would have happened if we had not done the linkage? So for example, in Washington State, we have Washington State Patrol that contains data on arrests. And then we have Administrative Office of the Courts that contain data on charges and convictions. And it was interesting when Vivian did these linkages, she found that there was not perfect overlap, as you probably would imagine, between the 2 databases. Had we not done the linkage, we would have missed some of these cases that showed up maybe in one database and not the other. The same for health outcomes or injury outcomes. She did a wonderful job trying to capture any databases possible in the state, from syndromic surveillance to ED data to inpatient data to care everywhere in EPIC. Those of you who are physicians, you are aware of this feature. death records, hospitalization records, variety of different things that need to be reviewed in order to find potential outcome for this study. Next. And the same here in terms of the ascertainment of time at risk. It's important to be able to link these databases to identify the amount of time that people spend in jail, the amount of time that people were institutionalized, so-called. And those are all factors that need to go into the calculation of time at risk. Next. So I think in terms of strength, I think it's needless to say, many of these things would not have been possible if we had just stuck with 1 or 2 data sets. I would say it would have been actually invalid results. Next. And in terms of challenges, yes, if you could please hit the button here. I think in terms of challenges, as I mentioned, there is a choice of software, which obviously is really important because there are so many different software packages that you could choose these days in R, in SAS, in Stata, and people are comfortable with different ones and they all have different features. So something for you to have in mind. The quality of data is very important. Some of them, for example, are for surveillance. They're not ready for research. Next one. Coverage of a statewide data. Some of these data sets may have the state and their name, but they may have some missing counties. Those are really important to include. We had those examples. Next, please. And then sometimes, the size discrepancies between the data set that you would like to link to another one may create some challenges in terms of probabilistic linkages. So that's something that you have to have in mind. Next. And next, please. So I'll just end by saying that linking across multiple data sources for outcome ascertainment is really feasible and beneficial. It requires a lot of work and planning ahead of time, but it definitely pays off because it really has direct bearing on the validity of the findings. So I think I still have 1 minute remaining, but that's the end of my talk. Of course, if you have any questions for me, for Vivian, please send us an email. Of course, this is just a very quick tour of what happens here. We also have within the FACTS Consortium and other colleagues really truly experts in data linkage, and you will hear from some of them next. And if you have questions about particular choice of software, please do feel free to contact us or contact them. Thank you very much.
Thank you, Ali. That was a great presentation. And I would remind you, if there are questions specific to this presentation, please do put them in the Q&A and we'll address them at the end of the talk. Next up is Dr. Kathleen Carlson, and I will turn it over to her. Dr. Carlson, I think you're on mute.
How is that? My worst nightmare come true. Okay. Now I need to get my slides back. Okay. So I'm Kathleen Carlson. I'm at Oregon Health and Science University and the VA Portland Healthcare System, where I'm an injury epidemiologist. And a lot of my research focuses on veterans injury, both rehabilitation of injury and also more upstream prevention of injury. So what I'm focused on today is a project that we undertook to link multiple federal and state databases together in order to capture more complete data on veterans' firearm injuries. And this was a demonstration or pilot project that we are now redoing with the knowledge that we learned from this earlier pilot. Next slide, please. I'd like to acknowledge my study team and co-authors. Importantly is our probabilistic linkage expert, Larry Cook from the University of Utah, and also Dagan Wright, who is our scientist colleague from our state health department, who in all the years that we've been doing this linkage work has been our guide on use of our state data systems. And he's in the Injury and Violence Prevention Division at our state health department. And the funding for this demonstration project came from the NIH. Next slide, please. Next slide. So I don't need to go into much detail on this slide other than to say that firearm injuries are endemic in the US. They aren't all fatal, so it's important to also look at the non-fatal injuries. And we focus a lot in the VA on suicide prevention among veterans, which is critically important, but it's not all of the firearm fatalities or non-fatal injuries among veterans even. Next slide, please. Military veterans are at greater risk of fatal injury in their early years post-deployment, and that's relative to veterans who have deployed even, but to non-combat zones. So there's something about deployment to combat, such as in and around Iraq and Afghanistan, like we've been doing for the past 20 years or so. They're also at increased risk for hospitalized injuries. And this isn't necessarily attributed to firearm-related injuries, but we do know that veterans have a higher prevalence of firearm ownership, so greater exposure, and also presumably more training with firearms than non-veteran US citizens. And so the area that's been my focus primarily is this post-deployment or post-9/11 post-deployment veteran group because of this higher risk of fatal and non-fatal injuries. And this is a large cohort of veterans with unique risk factors relative to veterans from previous combat eras. Next slide, please. So the objective of this pilot study was to develop the approaches for not just linking, but the sharing and the negotiation of joint use of linked data sets that would give us more information about veterans' firearm injury risk. And then with this linked data set to estimate rates of firearm injuries and hopefully to go more upstream to identify and hone in on risk factors for all firearm injuries, the spectrum, and coming from the VA healthcare system to think about mechanisms through which we could intervene at the touch points in the healthcare system to hopefully prevent injuries related to this singular mechanism. Next slide, please. Next slide. So like Ali was explaining previously, we also use probabilistic linkage to connect databases across disparate systems. Probabilistic linkage is a method that uses the properties of fields that are common to two or more of your databases to determine whether the probability that those two records are a match or a non-match is within an acceptable probability. And if so, then we link those records, or we don't link those records if they're not. And so through the process of probabilistic linkage, we'll create an integrated database then where hopefully we can have a data set with one row per unique individual, and then the information about their event or multiple events pulled into each of those rows. So in our case, when we link VA and DoD data sets together to identify our source cohort, we can use a unique identifier, and that's the Social Security number. But when we pull those data over to our state data systems to link to various data sets over there, we don't have access to Social Security numbers, but we can use first name, last name, middle names. We can use pieces of the dates of birth, we can use sex and pieces of the address to inform us whether there's a high enough probability that these unique records should be matched or not matched. Next slide, please. So as I mentioned, we linked VA and DoD data together to identify our source cohort. We pulled in VA healthcare records. This is pretty straightforward and similar to a lot of the work that we do in the VA. But then on the state side, for this project, we pulled in 4 different state data sources: our vital records system, our violent death reporting system, our state's trauma registry, and our hospital discharge data index. And for each of these data sets, we needed to go through, we needed to negotiate data use agreements and also the oversight of privacy and information security, having to do with the linkage of each of those sources. And those are unique per data system. So it's important to know that each data system you pull in will add another layer of steps that you need to go through in terms of data use agreements and management. And then also just the mechanics of the linkage can be different per data system also. So some of the data systems that we have accessed and linked to, we're able to get those data by mail, some even through secure exchange on the internet. But others that are more secure, more private, we needed to go on site to the state health department. And to do that, we had to get permission from our sources at the VA in order to take VA data off site. And then the state was able to work with us in person together to do those linkages and to, for them, ensure the privacy and ultimately the de-identification of their records once the linkage had occurred. So a little bit of different steps for each data set that we link to. Next slide, please. And this, and the next slide, boil this linkage down to 2 steps, but it's an oversimplification. But just to give you an idea that the first pass through on this particular linkage was to take the 4 state data sets and to identify the veterans in each of those data sets. Next slide, please. And then once we have our veterans flagged, we can link together the unique state data sets and go through a process then of deduplication of rows, let's say, that have the same, that are describing the same individual. So you might imagine, or as Ali was explaining, not all of the data sets have the same events when maybe they should, but also a lot of the data sets will have the same individuals, and you don't want, you may not want multiple rows per individual. If you want to do an individual level analysis rather than an event level analysis, then we want to condense that down to unique individuals and pull in the unique data that each data set offers to us, but exclude overlapping or duplicate information. Next slide, please. And then we're able to do the analyses with that integrated data set. Next slide, and next slide. Okay, so just briefly, with the initial 10 years of data that we linked together, we saw just under 7,200 firearm events. And this was a slightly higher event rate for our veterans and our non-veterans when we used census information for the denominator. But if you look at that number of raw events for veterans, the 104, that was considerably lower than what we had anticipated. And so we could look at, broad brush patterns of differences by veteran and non-veteran status. So if you look at the table there and you compare the veteran column to the non-veteran column, we may see that the proportion of fatalities or fatal firearm injuries among the veteran injuries was smaller than among the non-veterans. And likewise, that the proportion of hospitalized injuries was higher among the veterans than non-veterans. But we're getting down into a smaller number of observations, which as an epidemiologist makes me uncomfortable to report pretty, with certainty any of these trends until we have more numbers to look at. Next slide, please. But some of the patterns that we did see is that among the fatal injuries, which is this top table here, for both veterans and non-veterans, the largest proportion of those injuries were self-inflicted or the suicide. And then among the non-fatal injuries, which is the bottom table, we did see a higher proportion of unintentional injuries among the veterans than the non-veterans. And so when we replicate this study, or when we're looking at veterans firearm injuries in our other studies, we are seeing that a considerably higher proportion of veterans injuries from firearms are unintentional in nature. And that's something that we are interested in looking into in more detail. Next slide, please. Next slide. So in all, in this demonstration project, we had more limited takeaways regarding risk and outcomes of firearm injuries themselves than we had anticipated, but we did see some interesting trends that we will be looking into. Next slide. But what we really wanted to do was to learn about this linkage process and to be able to replicate that maybe across multiple states, maybe pull in different data systems, because they can be a fruitful source of more granular data on this source of injury than an individual administrative data set can be. So in our case, we get to look more at the broader spectrum of injuries from non-fatal to fatal, to from unintentional to intentional. And also what's unique about this linked data set is that we can conduct sub-studies that give us some information about the validity of some of the variables that we may be using. A primary example would be our firearm outcome, which we're relying on ICD codes in this case to help identify. And that can be misclassified as a firearm injury, yes or no, or misclassified by intent as well. So when we have a gold standard source of data that we link to another data set that may have less certainty about the outcome, but more information that is useful for the study, then we can conduct sub-studies to look at the validity of, say, this firearm outcome from the gold standard relative to what you might see in this individual data set that down the road you could use individually for a firearm injury analysis. So those validity studies can offer a lot to your overarching research program once you link data together. But for all of this work, those strong relationships with state data partners, with the stewards of each of the data systems are really, really important because what I haven't been able to include in this talk is the multiple smaller barriers that we might have encountered along the way. And for each of those, we had to problem solve in order to get the federal data systems and the state data systems and the oversight agencies to agree on the mechanisms that we could use for this. Next slide, please.
I think we're going to have to leave it there, unfortunately.
Okay.
Time, but thank you.
This is the last slide, so I'll be around for questions, or actually one more slide. And anyone who would like more information is welcome to contact me.
Thank you, Dr. Carlson, and we'll have some more time for Q&A at the end. Next up is Dr. Libby Alpern, and I'll turn it over to her.
Thank you. So I appreciate being asked to speak today, and I'm going to speak about a database linkage that is in an earlier stage than what Kathleen and Ali presented today, and hopefully to interest you in it. That's looking at hospital-based information of children, teens. I'd like to recognize, as you can see at the bottom of the slide, that all good research is a team sport, and my collaborators that are listed there have been very helpful, as well as the funding support through the FACTS Consortium and the PCARN HRSA grant of the Pediatric Emergency Care Applied Research Grant, as well as collaboration with the Children's Hospital Association. Next slide. So as we've already talked about today, research is significantly limited for children in the availability of high data quality on non-fatal firearm injuries across the spectrum of hospital care, including non-fatal injuries. And our goal to address this was to derive and link a multi-centered clinical electronic health record and administrative databases that would be patient-centered and hospital-based, that would contain all levels of severity in pediatric firearm injuries, that would have information across care settings, both in ED, inpatient, and potentially outpatient clinics, and that would allow us to longitudinally link patients across years to follow in outcomes. Next slide. So when we're starting with administrative data, we have to recognize the limitations imposed by that, being that it's retrospective and observational only, that there's significant risk adjustment factors that may be missing from purely administrative data, that outcomes may be limited, that we do not follow patients in ways to assess important outcomes, that much administrative data includes charges that are a billed resource and not necessarily administered, nor do they contain the results of the intervention. And that for, especially in firearm injuries, there's unknown accuracy of the ICD codes, and that these rely on proper documentation and coding. Often that's variable by site. Next slide. So we've looked to linkage to try and overcome these limitations and also exploit the strengths of differing databases that's been described already this morning. So we want to leverage the strengths of registries that allow us for important identification of case ascertainment, as well as risk adjustment, and has outcomes that we're interested in. Whereas our administrative databases would allow us to look at costs, utilization, and longer-term outcomes. Next slide. So I'm going to talk about the linkage of two databases. The first is the PCARN registry. This is an electronic health record database of ED visits within the PCARN network that is an automated abstraction of very clinically deep information from the emergency department only. And I'll talk specifically about each of these databases in just a minute. And our goal is to link this to the Children's Hospital Association Pediatric Health Information System database, or FIS. And that's an administrative database that includes emergency department, inpatient, and some ambulatory surgery and observation status visits that are derived both from the EMR as well as the billing system. What we are doing is a linkage, as Kathleen has described previously, though because each of these have unique identifiers on a patient level, we're utilizing the sites involved in each and doing a join as opposed to a probabilistic linkage. That allows us to use the exact identifier for each patient within each of the individual databases and to link them specifically. Next slide. This is the PCARN registry, and basically what I'll say is that it's a soup to nuts capture of what happens in the emergency department. It's very deep, clinically specific, including, say, all vital signs, all medications that were given, all labs and lab results, all radiology reports and results, as well as the narrative documentation. Next slide. And currently what we have is data in the PCARN registry between 2012 and 2019. We have 10 sites, including 3 community emergency departments and over 4.5 million visits, representing 1.6 million patients and over 25 million narrative documents, as well as 30 million result labs. Next slide. We're linking this to the CHA FIS database, which is much larger, 49 hospitals, and obviously a lot of inpatient cases, as you can see there, with ED encounters as well, and then significant information about charges and ICD codes. Next slide. The CHA, as I've said, has some information from the EHR looking at diagnoses, procedures, and CPT codes, but a lot of their information is from billing transactions. So you would know if a medication was given, you would know if a lab was ordered, but not the actual result. Next slide. Both of these databases have spent a lot of work doing normalization and harmonization of data. So an example here is Hospital A may look at vancomycin 125 milligrams, Hospital B, tablet 125 milligrams vancomycin. Both have done a lot of work to be able to identify that these two things are exactly the same and how we could utilize that information. Next slide. The hospitals that were involved in this linkage are listed here, and as with the dates included. And as you can see there, the ED data is represented in each of these, as well as the FIS inpatient data and some select outpatient data. Next slide. Next 2 slides, please. So the benefit of this is that it's an all-comer ED-based database that has a lot of children. Next slide. And our goal in this is that we're able to then identify cohorts of like patients that can be helpful in our research. Next slide. For example, we've already done this for asthma cohorts, viral infection, opioid use, long bone fractures, etc. Next slide. One of the first things that we're going to try and do with our cohort identification with our linked database is a validation of ICD codes in comparison to free text analysis. So what we'll do is identify by ICD code children that have firearm injury associated visits. We can identify that from both of the databases as well as follow-up care. And then this is an example of what we have in the free text available to us in the linked database. We'll then be able to do comparison by data abstraction as well as natural language processing and look at these assessments. And this will be important to allow us to understand our future work utilizing identification of patients by ICD code alone. Next slide. So the future work of our research with these linked databases will allow us to do epidemiologic and population-based estimates of the cohort of children that come to the emergency department with firearm associated visits. This will allow us to prioritize our research. Within it, we'll also be able to look at drivers of cost and longitudinally outcomes for these children, and ultimately to also do comparative effectiveness studies, because we can identify like children in a way using precision identification of cohorts with clinically important variables and allow us to look at differences in therapeutics and outcomes. I believe that's my last slide. Thank you for the opportunity to speak about this database.
Thank you, Dr. Alpern, and thank you to all of the speakers that we've had in this session. It was a really nice overview of a number of different data sets that folks are working with. We do have some questions, and I would encourage, as we get started with the Q&A portion, for folks who are to continue to submit questions, and we will get through as many as we can in these last few minutes. But the first question that came up, I think all of you talked about a variety of databases and data sets, and some that you linked deterministically and some that you linked probabilistically. And I think beyond just the availability of linking variables, are there specific decisions that you use to govern whether to link something in a more deterministic way or in a more probabilistic way? And sort of part of that question, I think also, if folks could comment on, are there specific, Ali, I think you alluded to it, was specific software or that you would recommend for new researchers who are trying to get into this space, and what are the pros and cons of that? I'll start there.
Sure, yes, I'm happy to share a few thoughts, and then of course I would love to hear from Dr. Carlson and Alpern. I think part of it was really in terms of the distinction between deterministic and probabilistic. Part of it was really governed by how those organizations or partners worked. So to just give you a good example of that. So my bottom line is, it wasn't all driven purely by science, but rather by the organizational nature of those entities. So to give you an example, in Washington State, we had Washington State Patrol. Colleagues would give us historic data through the data sharing agreement and all the nuances that Dr. Carlson mentioned. They would give us the data. We would house the data in our center, and then we would do probabilistic linkage. Administrative Office of the Courts, on the other hand, in Washington State, that had the charges and disposition, they would not do so. They would want us to provide the list of cohort members that we had, and they would deterministically look for the record in their data system. So it varies from one to another, and it really is governed importantly by how those organizations work. So that's for the first part. The second part has to do with the software, as you said. There are certain software packages like linking that we used mainly, or Dr. Lyons used mainly for this research, that were really suitable for the type of work that we were doing. Linking is a software that actually is written by colleagues in Washington State Department of Health. So the creator, the inventor of the software here is in this state. So of course, it was very, very easy for us to have a dialogue and conversation with them. When I talked to Dr. Larry Cook, for example, he said he had the same sort of arrangement with somebody else who was, I think, the creator of LinkSolve. And that's, you know, how, for example, they do their package, the linkages between different databases. There is LinkSolve, there is Link Plus, there are, you know, there is FastLink, there is Stata databases or commands like DTA Link, and others that are available. And depending on the nature of your study population, depending on the nature of your data set, those may vary. For example, give you another one. Some of them we found to be very Eurocentric. So they had some of these software packages, they had difficulty when the names or aliases of our patient population were not very Eurocentric. So the software would struggle with that. Or software packages that would struggle when the size of your study cohort is small, but the one that you want to link to is very large. So they would struggle with the relative probability of matching. So I'll stop there, but it's a very long list that you have to consider to see, based on priorities, which software might be preferable for you.
I guess Dr. Carlson or Dr. Alpern, do you have other thoughts to add?
Yeah, I guess I would just say that I've gotten the sense that we as humans are more comfortable with the idea of deterministic linkage because it allows human choice in that decision. But I think for those that are comfortable working with probabilities and large data sets and statistics and mathematics, they would say that probabilistic linkage is a better way to go, where you can parameterize your certainty and your uncertainty, and you let the data drive the decisions rather than humans who are prone to, making decisions that are erroneous based on whatever foundation we have. And so I try to, suggest to folks that probabilistic linkage has its benefits and is a more robust approach than deterministic linkages in a number of cases.
That's really interesting, and definitely takes into account bias in sort of human decision making. Dr. Alpern?
I think that Dr. Carlson's point is very interesting and important for us to identify, and I think also speaks to, interestingly, that all three of us collaborate with Dr. Cook, who's a world expert on this and has been so helpful. I'll also agree that our linkage, we did a join, and we were able to do this only by having collaboration with the sites. So each of the entities had de-identified identifiers, but each site had identified identifiers and allowed us to do a linkage and then de-identify at the site, so that we could still maintain the human subjects protections that were important for each of the databases. So it's sometimes just what you can do, and we had a backup of probabilistic linkage to check that out.
Very interesting. I have another question that has come through from our Q&A that I think sort of touches upon all of the things that the three of you have talked about. Given the growth of these data sets and the increased use of this methodology, how do you, so two questions really that come out of that. So one, how do you deal with issues of discrepancies between data sets that may contain similar variables, such as the ED data set and the inpatient data set or criminal justice data sets? And then what considerations do you think should be given as people design new data sets for how to think about structuring or including certain data elements that allow for this increased use of these methods as we move forward in the field?
I'll just start to say that, as I indicated, one of our goals is really to identify what could be a discrepancy. So I think one of the things to start with is just doing research that looks very rigorously at how good are we at these things. So what do our ICD-9 codes really, or ICD codes really identify? And that in itself is a really important work that we can then take to help us do further work. Beyond that, I think that it is, as we've said, always a limitation in existent or extant databases that, especially I do a lot of work with the EHR, and I always say what I have is the EHR reality. It may not be real reality, but it's what we have and it's the closest to it. And that can be both helpful, especially in comparative effectiveness analysis, and looking at biases of care, and it may be a strength in actuality, depending on what you want to look at.
Those are interesting points, Libby. The one other thought I had is that I have emphasized the importance of your relationships with the data stewards and the data owners in my talk. And this really comes through here as well, because you need to have someone on your team with familiarity with the data sets that you're using, because these discrepancies will come up all the time, whether through the linkage process where you need to know some of the parameters of the variables you're using to link with, or in the analysis process where you need to know which of the variables that you trust the most. And so, I may have the knowledge of the VA data sets that's kind of institutional or experience-based knowledge, and you need that. I mean, it's ideal to have each of the data sets that you pull in.
Yeah, I completely echo the points that you raised. First of all, it's such a great question that was asked. And I would say just one comment in 1 minute about the last part of that question that you asked, Dr. Carter, which is what to do, in this exciting new phase, as Dr. Branis mentioned and Dr. Cunningham this morning, what to do for new databases, what to do with things that can be built on new or modified at this really critical juncture. Historic time in gun violence research. And I would say I emphasize the importance of intersection or collaborations between research and practice. Those very individuals in your team, as Dr. Carlson mentioned, who are familiar with data stewards, who have connections with them, they may also have the influence to continue the conversation with them and say, are you amenable to changing your database to say within this state, to have this code, this common code, that would be used as a key across several of these databases. Let's say across all criminal legal system databases in state X. Can we do that? Can we make that happen? If we do that, that would really alleviate many of the concerns that we have. And then, as Dr. Alpern mentioned, also really focusing on the quality of the data that we already have. There is a long journey right there to make sure that those ICD codes are actually valid and accurate.
Absolutely. And I think we have time for maybe one final question. There are a number of questions that came up in the Q&A around, creating a comprehensive picture of a community by linking both hospital firearm injuries to, deaths that occur either downstream as a result of that or deaths that occur outside of the hospital, since we know that's such a large portion of firearm injuries. And I wonder, I know some of you touched upon that in your talks, but maybe if you want to touch upon, how you've done that or what you think are strengths of trying to approach that methodology.
I can just quickly react, which is, I think that is one of the rather easier ones. I mean, if I can use the term easy or less challenging ones, because the death records are typically available at the state level. I think because of the mobility of many of our patient populations, especially those who have sustained trauma and vulnerable populations, if somebody can use National Death Index, that will be even better in terms of the validity of their results. Of course, it may cost some money depending on what you want in terms of data elements from the National Death Index. But that will be critical to capture both in terms of censoring and competing risks for the analysis.
I don't know if Dr. Carlson or Dr. Alpern wants to add anything to that. All right. Well, I really appreciate everyone joining this session.